Gracias. Yo hablo un poquito de español y ustedes hablan muy rápidamente. So, I'm doing this in English rather than destroying your beautiful language by trying to do it in Spanish. As Fernando said, my name is Jeff Wall. I'm an obstetrician by background. I delivered babies for 22 years. I've been working at Cerner for 8 years now, and I'm Senior Director for Clinical Innovations, which is basically physician-doctor workflow within the electronic medical record, and about 50% of my time is spent on Smart and Fire and open standards. So we're going to talk a little bit, just two parts to this. The first part, I'm going to talk about how we are building interoperability into our EMR. And really, you can apply that to any EMR in the U.S. And then we're going to kind of talk about a lot of what James started to talk about this morning, earlier, about how Smart and Fire is integrating clinically and bringing those clinical apps into the EMR. Sound good? Do we have any doctors in the audience? Good. Nurses? Pharmacy? Okay. IT? Okay, good mix, great. Okay, so clinical interoperability is happening in the United States. When you look at what's going on, the Cerner has health information exchanges at actually in 5 countries around the world now: the United States, United Kingdom, Germany, Australia, and Qatar, of all places. We have over 55,000 connections at organization levels between Commonwealth and Care Quality, which are the 2 big systems for connecting records in the United States. And we now have about 70 million people connected just through those 2 services. Many countries around the world, and you'll fill me in on Argentina, but have national initiatives to start connecting their providers. Sweden, we work a lot in Sweden. You were asking about patient privacy in Sweden. Oh my God, you wouldn't believe what we're having to deal with there. It's a big deal. The NHS in the United Kingdom has that initiative to ban the fax machine. So this is growing globally. In the United States, as Aaron told you, we have passed laws to mandate that we have to pass data between organizations. You can't block it. It has to be easy for both the organization and the patient to get to their data. And if you don't, you're going to face pretty significant fines. And then we also have the direct trust, which is a way of passing secure medical emails between doctors within your organization and with outside your organization, so we can email through standard services, but still keep that patient confidentiality and privacy. So the connections are happening. Interoperability is happening in the United States. It's not perfect. We've got a lot to do, but it is happening. We had over 7 million just within the Cerner systems passings of what we call PAMI data: problems, allergies, medications, and immunizations. That, for the past couple of years, has really been the only thing that the U.S. government has required interoperability around: problems, allergies, medications, and immunizations. But we're starting, especially with the 21st Century Cures Act, we're building out what other information we will be passing, and some of it's already passing now, over 17 million direct messages. So the problem isn't passing the data, that's happening. The problem is now we're turning on a fire hose of information on doctors and nurses. In the past, when I was practicing in the clinic, if I was 2 hours behind seeing patients, I was hoping that they would not show up with a chart this thick that I knew would take me an hour to go through. It was easier just to reorder the medications and do everything. But now that we're sending all this information to your electronic medical record, you don't have an excuse to actually look at it and act on it. And it's mountains and mountains of data. So one of the big problems we're facing is how do we present that back to the user in a meaningful way? How do we retrieve the record from wherever it is And then how do we sync up that information? How do we normalize and clean up all that data that's coming back? How do we deduplicate? So if it found a lab test, the same lab test, say a blood count in 6 different places, how does it know if that's the same test 6 times or it's the same test 3 times in 3 other different tests? So it's the ability to actually look across it and say, how clean is the data? We have to be able to clean that up. So we have services and architectures that we're building that actually build out that longitudinal record. So as we start to clean that data up, it's how do we present more of the data? We want to go past the problems, allergies, the medications, the immunizations. It actually needs to have all the patient data. It needs to have, if they've been to the operating room and they've had surgery, we need the procedure records from the operating room. We actually need all the documents and all the notes from every doctor, from every consultant, from every hospital. We need to bring all this data together. It's labs, it's laboratory investigations, it's vital signs, it's x-rays, it's CT scans, it's EKGs, it's all that data. And that, when Aaron alluded to the advanced interoperability or interoperability 2.0, that's that full fire hose of data that we're turning on. So when we look at the patient record, we have, and this is just a sample of my EMR, Cerner EMR. Each EMR does this a little differently, but it's all kind of the same concept. We have the concept of trusted sources and curated sources. So we can see here, this is the patient's problem list, their medical problems. At the top, they've got 3 problems that we have found in other sources. We have found this information not in this EMR, but in some other EMR that we are connected to. And we can see off to the left now what those different sources are. So we can see that some of those sources are trusted. We know these people, we know these doctors, we know these nurses, we know this hospital. We trust the data that they have enough that we just allow it to come directly into the EMR. But we also have that concept of sources that we don't know that well, where somebody, a human, will have to say, yes, that we're going to bring over, this we're not going to bring over, that we are going to bring over. And you can see over, there we go, you can see off to the right now the ability to look at that and say, well, the data is correct, we're going to bring it over, or I need to adjust it a little bit, but we also keep the data provenance. So even when we bring it into the record from the outside source, we say exactly where it came from. It didn't come from this Cerner or this EMR, it came from this clinic on the other side of town or in this state. So that when you are looking at the detail of all that information, you still know exactly where it came from and the quality of the data that you're getting. And then we also provide a summary view so that in addition to your workflow, if you'd like to see all the outside data that's clinically relevant that has been reconciled to your record, we can bring up a view, a community view, that shows you everything that's sitting out there in a summary platform. And it's interesting, because as we talk about interoperability, we think about just about the clinical data, but we've actually had a fair amount of interoperability already going on for about the past 10 years in the United States. We have been, as far as medications go, we are really way ahead of the game in what we've been doing. For the past at least 10 or 12 years now, most doctors don't handwrite prescriptions anymore. You write your prescriptions in the EMR and you send it directly to whatever pharmacy the patient goes to. And they typically will tell you what their pharmacy is, and you locate that pharmacy. It could be on the other side of town, it could be in the hospital. So when I write a medication, Aaron's sick, and I send it directly to his pharmacy, he walks in the door of the pharmacy, they have his prescription ready. That's been going on for 10 years. That is administered by a third-party company called SureScripts. And every pharmacy in the United States is now tied into the SureScripts system. So we can provide that level of interoperability. That's happened for a while. Sorry, I went ahead of myself. In addition to being able to the electronic prescribing, there are other companies that have provided degrees of interoperability. Narcotic abuse, opioid abuse is a huge problem in the United States. Addiction is a big problem. Each state has what they call a PDMP, a prescription drug monitoring program, that looks at all the doctors, and there's 50 states, so there's a lot of these programs. Every doctor who prescribes a narcotic or an opioid gets listed in the state's PDMP program. So if Aaron comes in and he's asking for pain medications, I can actually look at his record and see what he's gotten from other drug providers. So here, another aspect of SureScripts is it also provides interoperability with the patient's insurance company. So when I'm writing a prescription, in this case for Ambien, I can see exactly how much this medication is going to cost at this patient's pharmacy. So building a connection between the doctor, the patient's preferred pharmacy, and then the patient's insurance company that ultimately pays for all that, I can see that this patient's medication is actually going to be pretty expensive if she goes to this pharmacy. But we can also provide lower cost options and say, well, if you go to a different pharmacy, you can actually, that's the way it works in the US, you can actually get it a lot cheaper. Or if you want, we can also provide you a therapeutic alternative. So you don't really need the Zolpidem, but you could use this medication and it's also going to be cheaper. So again, tying the payment systems into the prescribing systems and the insurance systems. This is our opioid response toolkit. And in this component, if Aaron comes in, he's in pain and he's asking for opioid medications and narcotic medications, I can look at his record, and it is scanning across all 50 states, United States, and it's looking for prescriptions for opioids. Based on that, it will give me a risk score for overdose and addiction. It will also show me every prescription that he's received at any pharmacy in the United States. It will show me the narcotic drug that he's received. It could be an opioid, it could be a benzodiazepine. And it will also show me the pharmacy where I've got that. So if I suspect that Aaron has an addiction problem, I can see where he's been getting his medication, and I can modulate, and I can treat him better, and actually maybe get him in touch with resources to better treat his addiction. So that's just some of the interoperability that's already happening. We're opening a fire hose with all of this brand new information. We've been doing it a lot already for the past 10, 12 years around what we've been doing with medications. But as James said, the world is changing and we need open standards. Everything that's been done before was really built on proprietary standards. Third-party companies that we had to either license the APIs from or that we had to work directly with. There was no open standard for us to create that interoperability. Smart and Fire brings that open standard that's being adopted by everybody now. And APIs have really changed everything that's going on in what we're doing in healthcare IT now. For the doctors, for the people who don't know what APIs are, basically an API, application programming interface, provides you with the connection, the socket and plug that allows softwares to talk to each other or devices to talk to each other so we can pass that data back and forth. And there's a lot of examples, and James talked about this a little bit too, of APIs in the real world. So Google Maps, probably the best map out there. I like that. Google Maps provides an API that other applications can consume. So Uber or a Cabify will consume the Google Maps API and will allow them to use Google Maps within their app so that when you're looking at the app, you can actually see where the car is and how far away it is from you and where it's coming from, and and say where you want to go. So an example of an API in real life. Smart and Fire are the two APIs that are really changing what we're doing in healthcare. Smart is substitutable medical apps with reusable technology. provides a set of services that allow third-party web applications to run natively within an EMR. FHIR, Fast Health Interoperability Resources, is that HL7 data set that allows that personal clinical data to pass back and forth between the smart app and the native EMR. Hope I did that justice, James. Yeah, okay. What that allows is it allows the EHR to become a platform for other applications. We can use that platform for user and patient management. That platform can assist with the core transactional activities, ordering medications, laboratories, things like that. It also helps facilitate that legal record of the patient's care that we're building. I'm a clinician. My job when I work with the Smart on Fire folks is to sit down. They're technical. They don't understand medicine. So the app developers will come and our software engineers will be like, oh, I think that's really cool. And I look at it and go, nobody's going to use that. No doctor would ever do that. So they bring them to me, and my job is to look at those apps and say, what's in it for the EMR and what's in it for me as a clinician? What is the medical side of this that's important? What does it do for the EMR? Well, it could improve the EMR. It could be that Cerner, Epic, Allscripts, Athena, NextGen, whatever EMR it is that's plugged into Smart and Fire, does something, and they do it okay, but there's an app out there who actually says, well, we think we can do it better. An example of that is, we have growth charts, pediatric growth charts in our EMR, perfectly functional. Pediatricians are happy with it. Boston Children's Hospital in Boston in the US actually built an app that is way better than what we do. So improving the experience of their doctors, plugging that app into their EMR just like you plug an app into your phone. So it can improve existing functionality. It can also fill gaps. There are things that EMRs do, and there are things that EMRs don't. There are things that we should do that we don't do because we just haven't gotten around to it yet. So a lot of these apps now can start to fill the gaps in functionality they're lacking in our EMR or any EMR. And then lastly, they could extend the functionality of the EMR. James alluded to this. If I leave the house without my phone, I feel absolutely naked. If I've driven across town, I will actually drive back home to get my phone because I am so tied to this thing. And it's a telephone. And if you had told me 10, 15 years ago that this thing would be running my life, I'd have said, you're crazy. But it's so much more than a telephone now. Yes, it's a communication device, but the apps, the applications on the device now have brought new levels of functionality that I could never have dreamed that I would use. All my boarding passes to get home are on my telephone. All my pictures are on my telephone. I communicate by voice and by text with my family. I play games, stupid, time-wasting games on my phone. I do so much on this thing. It kind of runs my life. It's how I stay connected with myself, where I'm going, what I'm doing. I have a friend who has atrial fibrillation, funny heartbeat. He has on his iPhone, he's got a case that has 2 metal pads on the back of it. Whenever his heart is beating funny, he puts his fingers on the back of the case, it takes a rhythm strip and sends an echocardiogram off to his cardiologist, who then looks at it and either tells him, oh, you need to come in or adjust your medication. Whoever thought that you could manage your cardiac disease, your heart disease, with your telephone? So we haven't seen many apps yet that are extending where you look at it and go, I had no idea I could do that with my EMR. But that's what's going to come next. When you first got your smartphone, you didn't know what to do with it, but now you play around in the App Store and you find all this really cool stuff. I also look at it as a clinician and say, well, what does it do for me as a doctor? How does this make me better? Is this an app focused on patient care? Is this an app that helps me be a better doctor? Is this an app that just helps me be more efficient? when I'm running around in the clinic and I'm hours behind? Is this an app that helps me see patients faster or do my work better or faster? Is this an app that helps me make money, helps me make sure that I bill appropriately, or helps me hit my regulatory needs? The government says I need to do these things, or there's quality things I need to do. Is it an app focused on that? So every time a new app comes by, I'm looking at it and asking those 6 questions. What does it do to the EMR? Does it improve? Does it fill gap or extend? And what's it do for me as a doctor? Is it about patient care? Is it about efficiency? Or is it about how I make my money? How I run my business. So these apps can do a lot of different things. And what I'm going to do is I'm going to run through just a couple of the apps just to give you kind of a flavor for what's going on out there, what we're seeing developed. And this is really just the beginning. When I started working on the Smart and Fire program about 4 years ago, we would get an app for review about once every 6 months. Now I'm typically reviewing 2 to 3 new apps a week. We have over 2,600 developers already working with our engineers developing apps against our ecosystem. We put them through a very rigorous validation process. 33 have gone through it, but we're going to continue to see the number of apps grow. So, first off, and James talked about this is Apple Health. It's available in the United States, but Apple has an app now that ties into your EMR so that when you log into that app, you can get access to all your personal health data. So Apple facilitating that through the Smart and Fire, your access to your own personal care. Now, it's only on Apple devices, so those of us who use Android, we're out of luck, but my wife can get all her stuff. Some of these apps are just very simple functionality. This is the ASCVD, atherosclerotic cardiovascular disease app. It's a very simple app. All it does is really predict your risk for heart disease. So a doctor or nurse can sit down, plug the information in, and start to talk with the patient and have those conversations around shared decision making. So that's just a very simple app. This is a more complex app. This is Visual DX. This is an app. This company has actually been around about 15 years. Traditionally, they were an application that you installed on your computer, or you went to the website and you had to leave your EMR and you had to go into this other app and you had to log in. Now this app is built directly into the EMR, and they have the world's largest collection of dermatologic skin pictures. So a patient comes in and they got this funny red rash and you have no idea what it is. You can go in here and it will walk you through the differential diagnosis and help you come to the correct diagnosis and provide you with some treatment recommendations for all these weird and funky rashes. And kids get all kinds of funky, weird rashes. This is an application from a company called Empathic. It's specifically geared at the emergency room. When patients come in with chest pain, it provides a series of clinical pathways to walk the doctor through the steps. Is this a patient who immediately needs to go to the cardiac cath lab? They're having an acute event. Is this somebody who needs to go to the floor and be monitored? Or is this somebody who can send home because they just have an upset stomach? So walking the doctor through chest pain protocols in the emergency room. Some of the applications have both a provider, a doctor interface in the EMR, as well as a patient interface. We'll talk about 3 of them. The one on the left is Seamless MD. It works with what we call ERAS protocols, which is enhanced recovery after surgery protocols. So in this app, the doctor logs in and they send the patient activities and questionnaires and things to do after they've had their surgery when they're at home, and the patient records their progress at home. And it's been shown to decrease the number of post-operative complications. This app here, Remedy, is a diabetes management app. So the patient gets the Remedy app on their phone. They connect it via Bluetooth to their glucometer. So whenever they check their blood sugars, it's automatically synced to the app. They record their calories, their diet, their exercise. And then when I log in to that patient's record in the EMR, I now have a complete understanding of their diabetes management at home. So the patient's doing it real time. I don't actually have to sit down. I could review it before the patient even comes in. So I sit down with the patient and immediately have a conversation with them about their diabetes management. This is another one. This is getting a pedigree can be a very difficult job. So with this app, the patient logs in on their app on their phone with their family. They take a complete family history, and then once they sign that, it's immediately available in the EMR, and then I can look at it, and if I need to, sit down with the patient and adjust and refine their family history. This is a company out of Australia called DoseMeRx, who provides clinical decision support at the time of ordering for some very difficult medications. And it's typically the medications that you really have to tweak and you have to play with to get at the right dose. You have to manage the peak and trough levels. So using their algorithms in the app, they look at the known pharmacokinetics of the drug that you're prescribing, they match it to the personal pharmacodynamics of the patient, and they provide you with guidance on getting to the correct dose for antibiotics, for chemotherapy medications, for transplant medications, and for anticoagulation. So providing you better, really right at the elbow support at the time you're ordering. This is an app called ePreop. It was started, a company started by an anesthesiologist who was tired of patients showing up for surgery who hadn't been prepared for surgery correctly. Either they had a lot of health problems and they needed to see the anesthesia and the operating team ahead of time to get labs and things done, and they didn't, or they had patients who showed up to get prepped who didn't need to be prepped because they're actually healthy. So really a way for an anesthesiologist to sit down in the system and figure out the best preoperative protocols. So it goes nicely with that other one, Seamless MD. There's a lot of patient education apps out there. This is my favorite one. What's interesting about this is the new app development, Smart and Fire, is actually opening up the world to people who aren't medical. It's providing a fresh set of eyes from other industries who are looking at medicine and saying, I don't know why you do it that way. That's kind of crazy. So this app is a patient education app. The founder of the company came from the music business. He owned a large music magazine in the US called Spin Magazine years ago. He very tied into the music industry. He looked at it and he said, nobody has ever applied the concept of Spotify, you know, the music app Spotify, to the EMR. So he went and he now connects to over 230 professional organizations, the American Diabetic Association, all the colleges and all that provide a lot of very good free patient education. And then you as the doctor, the nurse, basically build out a playlist of patient education that you're going to send, and you can save those playlists and you send it to the patient. And when you can send that playlist to a text, you can send it to an email, or you can send it to the portal. And then when the patient clicks on that text, it brings up all the patient education. I get a report back so I can see that the patient actually looked at the patient education, and it opens up a chat bot at the same time that then connects the patient with other programs. So it could be that I sent Aaron, he wants to quit smoking, and I have sent him some patient education around quitting smoking. As soon as he opens that, it opens up a chat bot, and the chat bot says, well, you know, at our hospital we happen to have classes, a program for quitting smoking. Would you like to join? So not only just giving him patient education, giving me, the provider, the chance to know that he's actually looked at it, and also tying programs that you provide at your hospital back into the patient care. Really cool app. This one, I love this one. This is Tissue Analytics. They have an app on their phone, a camera app on their phone. This is for wound care management. You put that green dot on there, and then you take a picture of the app. The green dot color normalizes it and space normalizes it. Almost done. And then it runs a bunch of advanced analytics on the wound that shows you areas of healing, areas of infection, and then you can take a picture every day, every couple days, and track how the wound is healing or not healing if it's getting worse. So your wound care doctors and nurses could be using it. You could also give the app to the patient. The patient goes home, puts the green dot on there, takes the picture, and then I can look at that picture in the clinic and tell that patient, you're fine, keep doing what you're doing, or we need to get you in, or let's get you on some antibiotics or something. I personally used this recently on my dog. My dog had some surgery and she chewed up and licked and chewed up her, and she got this big wound on it. I used the app, if anybody wants to see the pictures, and we tracked the healing of the app. My veterinarian loved it. It's both. It's an app, it's the camera app, and it's the provider app. And you just buy those green dots. Or you get, yeah, you put, yeah. This is an application here for surgical documentation, just helping surgeons write a better note in a graphical fashion of what they actually did at surgery, better communication to themselves and their partners. This is Juxley timeline. One of the big things that people complain about with the EMR is that we've lost the patient story. It's hard for me to figure out what actually happened to the patient because there's so much data. So this provides a timeline format of all the different events that have happened either during this patient's outpatient care or since they've been in the hospital. When did they come in? When did they get labs done? When did they get vitals done? When did they have their medications done? And a nice scrolling. This is one that the nurses absolutely love when they're changing shift and they want to figure out what happened last shift, and what do I need to tell the nurse who's coming on. This is advanced directives or living wills. These are often hard to find. Older patient comes into the hospital, is signed a living will that says, just let me die, don't do anything. If you don't have the proper paper, a lot of times they end up getting a lot of care that they didn't want. So with this app, the patient and their general practitioner, their outpatient doc, they fill out the living will, they upload it to the cloud. When that patient gets admitted to the hospital, we can immediately pull down the latest version of their living will, and we can figure out, yes, they want everything done or they don't want anything done. So we're always up to date on that. Very simple app. This is an app. It's focused not on doctors, nurses, or pharmacists at all. This is on social workers. So as the patient's getting ready to go home, how do you tie the patient back to all the different social programs that are available for them out in the community? So the apps don't have to be focused on your providers. They could be focused on the other people out there, the care managers and social workers who help take care of your partners. And then this one I like because I'm an obstetrician, providing clinical decision support on how to manage labor. Telling me when this patient's getting into trouble in labor, when do I need to intervene and do a C-section. So a lot of and that's not all the apps, that's just the tip of the iceberg. There's a lot of apps out there that are being developed that I think this is some of the most exciting stuff going on in medicine right now, because there's a lot of, and these are some of the companies, this is by far not all of them. Again, like Aaron, I couldn't fit all of them on one slide. But there's so much happening, and it's happening from commercial providers, companies who are creating apps, but we're also seeing a lot of hospitals partnering with academic medical centers, medical schools, partnering with the computer science department at the local university, because a lot of doctors and nurses have a lot of really good ideas about what they'd like to do with the EMR, but they never had a way of doing it. So now we're seeing those partnerships. So undergraduate or students helping to build apps with doctors that are deployed locally to their hospital system. And then we're also seeing tying in a lot more of those consumer apps, either a straight consumer app like Apple Health, where I just want to see my record, or those consumer apps that tie my diabetes care directly into my EMR and my direct care with my physician. And it gets back to something that we talked a lot about in the past, which was best of breed versus an integrated EMR. An integrated EMR does everything. It does everything that you think you need, but there's always a drawback. It does some things really well, but some things not so well, but you like having everything together. The best of breed mentality says, no, I'm going to buy the best system out there for my intensive care unit, I'm going to get the best system out there for my obstetricians, and I'm going to get the best system out there for my pharmacists. But in the past, typically all those systems didn't talk to each other, and you, the IT department, were stuck managing all these different systems. So what Smart and Fire and this allows is to bring all these apps into a single ecosystem that runs directly within your EMR. So now you don't have to worry about about whether the ICU system is going to write to this system or whatnot, they're all, through those Smart and Fire standards, working within your EMR. And it doesn't have to be Cerner. It could be Epic or Allscripts. Epic has their Apple Orchard, their gallery. Athena has an app gallery. Most of the big EMRs in the U.S. now are on board and have their implementations of the Smart and Fire APIs. So for the developers, they don't have to go and write an app that works in Cerner and then write another version of it that works in Epic and another version of it that works in Allscripts. They write one app and it works across all those other systems. So as a developer, as an IT department, it makes it very easy. There's just a single implementation. Cerner, we manage it all from the cloud. So all you have to do is tell us and we'll turn the app on for you from the cloud. You don't even have to do a project around it. But it brings up part of the problem with my phone is I have a lot of junk on my phone also. I've downloaded a lot of apps on my phone that I thought were valuable and I've never used. So when you look at these medical apps, you really have to put some type of governance structure, and you have to ask the question, does it fill a need for my hospital? Does it do it quickly? Am I not? Does it simplify the work? I don't want to put an app in that's going to make it harder to do my work, and do I really need it to do that? So you have to have a governance structure in place to look at these apps. Otherwise, you're going to end up with a phone like mine that's got a lot of junk on it, and you don't want that in front of it. So you need to have representatives from all the different departments. Clinical, you need to have finance because somebody's got to pay for the app. You have to have your IT department. You want your nursing. You want somebody who, like me, who's going to be that clinical lead. You have to build a governance structure around that before you start implementing these apps. So you need an IT department to make sure that you've got the ability to run the apps, that you have the APIs installed. You have to understand all those different pillars of does it fill a need, does it work well. You have to have that governance structure in place. Then you have to look at the apps that are already running and then that you may have running, and so you have to keep track of those over time. And then you also have to go out and explore. And as the apps grow, it's going to be harder and harder to find good apps in the App Store. So you have to have that governance built behind it. And in the future, I said that the EHR becomes a platform. Really, in the future, the electronic medical record becomes the healthcare operating system for your hospital. And that's all I got. Thank you.